Hello, everyone. Good morning, good afternoon, good evening. Thank you so much for joining. We will give just a moment for some more people to join, and then we will go ahead and get started. All right, so we will begin again. Good morning and good evening, wherever you are in the world. Thank you all so much for joining today's session. So today's webinar is hosted by Hepatitis Delta Connect. My name is Beatrice Zovich, and I am a Public Health Program Manager at the Hepatitis B Foundation and the manager of Hepatitis Delta Connect. Thank you so much for tuning in today. Today's webinar is focused on the work and research of Dr. Malika Khodjaeva, who has done extensive work on the epidemiology of hepatitis delta virus in her home country of Uzbekistan. We will have an opportunity today to hear from Dr. Khodjaeva, who will share an overview of her contributions in this area, particularly as they relate to gaining a better understanding of the profile, impacts, and outcomes of this generally poorly documented and poorly understood hepatitis delta virus. So we are looking forward to a great presentation today. Next slide, please. So before we get started, I would like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat button, and we will address the issue as soon as possible. At any time during the presentation, you can enter questions into the Q&A box. Questions will be addressed by Dr. Khodjaeva at the conclusion of the presentation. This session is also being recorded, and the presentation will be shared following the webinar. Next slide, please. Thank you. So just a quick overview of our program before we get started. So Hepatitis Delta Connect is a dedicated program of the Hepatitis B Foundation established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support to those who are living with and affected by hepatitis delta through a variety of channels, including email and phone consults, social media, newsletters, blogs, posts, a website, and focused advocacy and webinars such as this one. We also run hepatitis delta focused events and lead public health research projects, and we are hoping to continue to build and expand our programming throughout 2025 and the years to come, and we will keep you posted about these developments and further opportunities to get involved. Next slide, please. Thank you. So today we are very excited and honored to be joined by Dr. Malika Khodjaeva, who is a researcher and specialist in public health and infectious diseases at the Research Institute of Virology in Tashkent, Uzbekistan. Dr. Khodjaeva is a member of the International Department of the Research Institute of Virology at the Republican Specialist Scientific and Practical Medical Center for Epidemiology, Microbiology, Infectious and Parasitic Diseases. Her published works include clinical and molecular genetic parallels of HDV infection and the medical impact of hepatitis D virus infection in Uzbekistan. She has also served as a program coordinator for the Pluto project, which stands for Prevention of Virus-Induced Liver Cancer in Uzbekistan, the Tashkent Hanover Liver Network. She has worked in conjunction with Hiroshima University in Japan and has obtained a Master of Public Health degree at Essex University in the UK. And she has a medical degree in infectious disease and has worked in pediatrics as well. So very accomplished. And we're very excited to hear from Dr. Khodjaeva today and are grateful to her for joining us. So again, we invite audience members to put any questions you may have in the Q&A box as they arise, and they will be addressed at the conclusion of the presentation. So without further ado, I will pass it to Dr. Khodjaeva to begin the presentation. Thank you so much. And I will share your slides. Just give me one moment. Okay. All right. Are you able to see them?
Okay. Thank you. Good morning and good evening to everyone. Thank you so much for your warm introduction, Beatrice. I'm honored to be here and to share the information about hepatitis delta virus in Uzbekistan. It's with my presentation, it's hepatitis delta virus in Uzbekistan, a deep dive. I hope that my presentation will be beneficial both for the professional community and for the people who face this disease in their daily life. Next slide, please.
There we go.
It's okay, yeah. It's first of all, I would like to stop on the plan, which one I would like to share with you. It's a pathogenesis of HDV for the patient, for the people who doesn't relative with this uh, issue. Yes, epidemiological situation of HDV in the world and Uzbekistan, prevalence of liver cirrhosis of different viral etiology in Uzbekistan, population screening, complications of HDV, its diagnostics and treatment, and for sure, it's a plans for the 25-30 in Uzbekistan. Next slide, please. So about pathogenesis, it's hepatitis delta virus is an RNA containing virus from the delta virus genus. So it is highly infection and is a defective companion of the hepatitis B virus, since they require the HBV surface antigen for its life cycle and in viral formation. The HDV genome is represented by a single-stranded circular RNA, the smallest among human RNA contain virus. The virus uses cellular polymerases for replication as it's like its own polymerases. Viral hepatitis delta enters cities by binding via the large HBV surface antigen, L antigen, LHBs antigen to the receptor sodium torcoate co-transport polypeptide, which is involved in transporting bile acid cell. And it's a known 8 genotypes of viral hepatitis delta. Next slide, please. Estimate of the epidemiological, it's chronic hepatitis delta is a serious and often overlooked infection that coexists with chronic hepatitis B and significantly accelerate liver damage. The presence of HDV in individuals already infected with HBV heightens the risk of liver cirrhosis, hepatocellular carcinoma, and other severe liver-related complications. This dual infection leads to faster progress of liver disease and has a greater likelihood of resulting in chronic conditions of malignization. According to the World Health Organization, an estimated 5% of people with a chronic HBV infection are also infected with the HDV. It's approximately 15-20 million people globally. The clinical impact of HDV infection is particularly severe as it not only increases the severity of liver disease, but also contributes to high morbidity among those of working age, leading to social and economic burden. In Uzbekistan, chronic hepatitis delta represents a substantial medical and social issue. It poses a heavy burden not only on the affected individuals, but also on the healthcare system and the broader society. Next slide, please. Within 2021, 2022, the Institute of Virology and the CDC conducted a serological study. We are currently processing and preparing the data for publication. It is not published yet. The study objectives were determining the prevalence of HCV, HBV, and HDV infection, as well as the prevalence of chronic B, C, and Delta infection among children population and adult population in selected region of the Republic of Uzbekistan. It was done in 7 regions of Uzbekistan from 13. And next object was to identify a risk factor of HCV, HBV, and HDV infection in the Republic of Uzbekistan. It is we see the behavior risk factor, parental intervention, and etc. Next slide, please. So, as I told earlier, yes, study design was done of the 2-stage cross-sectional single-stage study of the cluster sample was conducted in 7 of 14 regions of Uzbekistan. 7 out of 14 regions were selected for study based on the population data. At least half of the population lives in the study region. Different prevalence of hepatitis in these regions, including regions with low, medium, and high prevalence. Next, please. So our presentation is more about the B and Delta infection. That is why I will stop on B infection and also on Delta infection. So how we did the testing for the HBV? It is all people come and we we see we did the total anti-HBsC. Then who was the positive? It was the H-based antigen. We tested for the H-based antigen. After that, who was the positive? We tested for the HBV DNA. And who was positive, we tell them that it is they have the HBV infection. So the same is if it's total anti-HBC was negative, we tell them that they doesn't have any illnesses with this testing. Next slide, please. As you can see, among the population, adult population, it's a hepatitis B was HBs antigen was in 6.74% in Kashkadarya and Kharazm region, 7.12. It is higher in these 2 regions. And all from 9,439 people, 495 people has this HBs antigen positive test. It was test for positive. It is 5.25%. And it was HBV DNA positive for the 3.56%. Next, please. So who was the HBs antigen positive person? We screened them to the anti-HDV. And if it was the RNA positive, if they have the positive test result, we did the HDV RNA, and after that, we tell them that they have the positive infection. And next slide, please. You can see it's mostly in Andijan region and in Kashkadarya region again count. It is 15.79 HBs antigen positive patient in Andijan region. It was the HDV RNA. And same 13.64% people from the HBs antigen positive people has in Kashkadarya region. And in total, it is 8.69% people who are infected with the HBs antigen. They are also infected for the HDV RNA. Next slide, please. And all these people we did preliminary results and demographic tests, and all these people were unaware at the time of screening that they had hepatitis delta. They thought that they were healthy and leading normal lives, and they're ignoring further increasing the risk of transmission. And you can see it's mostly was the people who has just in education, just the school education, mostly about the age. It is from adults age. It's a 35, 90, 49 people. It's an age group, yes. And a number of responded by gender, it was females more than males. Why? Because a lot of male in our region, they are working in another countries, and they are like in worker. Yes, it's and that is why it's a more female coming together with the children and tested together. Next slide, please. So we also did the very interesting test. We also did the very interesting research about the prevalence of chronic viral hepatitis among the person with the HBs antigen detected in blood for the first time. According to the research, finding the delta antigen among inactive HBs antigen carriers early on can give a good idea of how the disease will progress. Since some HBV infected people are in the inactive carrier state, which means they have a normal level of transminases and the virus doesn't replicate much. We did one more study to find out how often the hepatitis delta virus is found in people whose blood has HBs antigen for the first time. For this purpose, we examined 703 blood plasma samples from 40,000 people who applied for the blood donation, which is 1.8% of those who wanted to donate the blood samples to blood center was detected that they have the HBs antigen. And we see these blood samples for the delta antigen for anti-HDV, and detected in 9.8% of these cases was the HDV, anti-HDV detected. And we also tested all anti-HDV positive samples for the HDV RNA. A percentage of HDV RNA in blood was detected in 65%. Both screening for ALT, AST, bilirubin, and total protein, all parameter was in normal. The study highlights the importance of screening for HDV in individuals with a newly detected HBs antigen, as it helps to understand the prevalence of HDV co-infection and its potential impact of the disease progression in HBV carrier. All newly detected patients for all viral hepatitis are registered in the country's hepatology center. Next slide, please. So a little bit about the hepatology center. Hepatology center is established in Tashkent, firstly, and then in all regions of Uzbekistan. And in Tashkent, it was established inside the Institute of Virology in 2017, which created a database of patients with the chronic viral liver disorders required as outpatient hospitalized inpatient from all over Uzbekistan. Only the Research Institute of Virology have database for all patients with a chronic liver disease with HBs antigen etiology and examined for marker of delta hepatitis. Next, please. So in 2018, the epidemiological situation in the Republic of Uzbekistan attracted the attention of Mario Rosetta, and together with Professor Mario Rosetta, we conducted an assessment of the burden of viral hepatitis in Uzbekistan. Let me introduce Mario Rosetta, who doesn't know him. He, in 1977, Mario Rosetta discovered a new antigen antibody system associated with the chronic HBV infection called Delta. This discovery was made possible by the use of the double immunofluorescence technique mastered early in London. The Delta antigen turned out to be a marker for new virus, hepatitis D virus. The discovery was a significant step in the study of viral hepatitis, especially in Southern Europe countries where the problem of hepatitis B was most pressing at that time, and now it is globally. Next slide. So in 2018, we conducted a retrospective analysis of the case histories and examination chart of 6,589 patients with chronic hepatitis delta of viral etiology who presented to the Republican Clinic of the Research Institute of Virology between 2016 and 18. Then we then published the data in the Lancet, continuing this the work. The graph shows that liver cirrhosis of delta etiology is more common than liver cirrhosis of the HBV and HCV monoinfection, and this trend is getting stronger every year. In the compared group, the mean age of the patient with the HCV was significantly younger compared of cirrhosis, HBV, and HCV. The rates of the hepatitis delta related cirrhosis are steadily increasing between 18 to 2023, reaching level comparable to those of HCV. However, unlike HCV, there is still no complete cure for HCV to data. And to mean age of HCV infection was 39 years old. HBV infection was 45 and HCV infection 55. Patients from across the country with cirrhosis receive routine and emergency treatment at the clinic based of the Research Institute of Virology. Next slide, please. So next step, it was analyzing the demographic characteristic of patients with liver cirrhosis of HCV etiology, hospitalized in the study, and found the following data. It is 19.6 of patients were younger than 30 years old. It is very, very young generation people. 21% of them had a history of the blood transfusion or blood component. So we should to pay big attention for the blood transfusion centers. It is now it's we are doing our country doing very good job, but anyway, we should to pay attention more. So 7.5% of the patients had undergone surgical intervention. And in 69.5%, it was not possible to establish an epidemiological history. This data further confirms that HDV infection can affect a wide age range, and in the majority of cases, it is difficult to identify the source of infection. This underlines the need for improving screening, epidemiological monitoring, and prevention measures to control the spread of this infection. And so the child-Pew classification divided all patients into three groups. So was divided to class A, B, and C based on the severity of courses and degree of function liver failure. Next. So deeply about the Child-Pugh. Child-Pugh scale is the standardized tool for assessing the severity of liver disease, especially in patients with cirrhosis, including hepatitis B and delta cases. It is based on the following parameters: bilirubin, albumin, international normalized ratio, ascites, and liver encephalopathy. And we are giving the 1, 2, and 3 points. And after that, we are summarizing and putting the class A, B, or C. The Child-Pugh scale is used to predict patient survival and assess indication for liver transplantation. And if we will see the 1-2 years of survival, it's a class A, it's giving more than 85% good results. So class B, it's 60, 80%, and class C is less than 45%. Next slide, please. The provided graph displays the annual rates of patients from 2018 to 2023 with hepatitis of various etiology. It's a B, C, and Delta. And K observation, it is HBV class A and C have elevated low rate of compared to class B. There is a slightly increasing in the number of patients in classes B and C by 2023. HCV, hepatitis C, classes A and B show significantly higher rates compared to class C. Throughout the year, there has been a gradual decline in patients in class A. Class A also, while class B has, excuse me, class A, while class B has considerably higher number. Class C remained with the minimum changes. But if you can see on HDV, there is a sharp increase in the number of patients, especially in class B. Class A also show a step increasing in the number of patients, and class C shows minimal growth, remain low compared to the other classes. And hepatitis D, especially class B, show a significant increasing in the number of cases compared to the B and C, hepatitis B and C. This, despite declining rates of HCV class A, the overall number of patients with HCV remains stable. The comparative low rates in class A and C for HBV and HDV required. Next, please. Launched in 2017, the National Program of Viral Hepatitis Elimination primarily focused on HCV control, including elimination as well as timely treatment and prevention of HBV transmission. However, the result of study conducting under the program highlighted the importance of introducing HDV screening in Uzbekistan. And you can see that it was a decree, a presidential decree, firstly done in 1721. Then we did, Institute of Virology together with the CDA Foundation did the You Have One. It is pilot program, and then You Have Two. It was a more bigger program. And after that, after our results, presidential decree was done in 2022. For 2022-2025, and it is a screening for the HBV, HCV, and treatment of chronic HCV infection. But next slide, please. But anyway, we are trying to including testing and screening for the HDV viruses. And for this reason, the implementation of the following phases was gradually stated in 2022 together with the HCV and HBV. And some of these steps, which one we are also doing for the Delta hepatitis, it's the implementation of screening tests throughout the country to detect the viral hepatitis B and C, and also will be for the D, who is positive for B. Hepatitis B infection vaccination among medical personnel who work with the blood and its component, ensuring the full supply of consumable reagent and test kits for the detection of the viral infection in the primary care system, establishment of and management of a single electronic register of chronic viral liver disease, conducting scientific research on viral infection and implementation and of an automated infection control system, improving the monitoring of the safety, quality, and efficacy of vaccine test kits and antiviral drugs, and surveillance of HBV-C patients for cirrhosis and hepatocellular carcinoma. Next slide, please. And this is the 4 areas, which one the Research Institute of Virology and CDC that have been developed to support the initiative to eliminate viral hepatitis in Uzbekistan, including viral hepatitis D. It is development of 5-year national strategy for the elimination of viral hepatitis 2630, strengthening the capacity of the regional laboratory and primary healthcare facilities, HBV microelimination program for patients in hemodialysis center, hematology and oncohematology department, and developing tools for public awareness campaign. Next slide, please. So the national program to retard is mainly focused on hepatitis B and C viral infection, reflecting the high importance of this infection in the disease burden. However, the program also has a number of studies on hepatitis D virus. These studies aim to investigate the epidemiological, characterize the clinical course and treatment option for hepatocellular carcinoma. In particular, projects such as Pluto are working to better understanding the impact of the HBV plus Delta on the progression of liver disease and to develop targeting prevention and treatment and interventions. It is a program together Hanover Medical Institute. It is for the early detection of the hepatocellular carcinoma in Uzbekistan. Next slide, please. So let me tell a little bit about the hepatocellular carcinoma. Hepatocellular carcinoma develops gradually, rarely occurs in a healthy liver, and most often appears against the background of progression of chronic liver disease. Patients with chronic hepatitis B, C, and Delta, fatty liver disease, alcoholic liver disease, and cirrhosis are at the risk. Hepatocellular carcinoma is the most common type of liver cancer. In 2018, there were more 700,000 new cases and 600,000 deaths worldwide, increasing incidence of hepatocellular carcinoma in high-risk patients, such as those with viral hepatitis, NASH, or cirrhosis. Hepatocellular carcinoma develops gradually, rarely in a normal liver, and much more frequently as the liver damage progresses. As you can see, it's a normal chronic liver cirrhosis and hepatocellular carcinoma. It's detected in these pictures. Next slide, please. Yes. What kind of the standard test for the evaluation of patient with the HDV we have? In Uzbekistan, all patients with the HBV and their antigen are advised to undergo comprehensive abdominal and peritoneal ultrasound examination to identify signs of liver cirrhosis or hepatocellular carcinoma. And laboratorial, it's a LSI for detection antibody for the HDV, PCR for the HDV RNA, liver function test, LTST and bilirubin, general blood analysis, blood creatinine measures, and a recommendational instrumental study, abdominal ultrasound, and a liver elastography. It's a serum-based test like EPRI and FIB4 if elastography is available. But we have the elastography in our Institute of Virology. Thank you for this project. We have the ultrasound together with elastography. Additional serum alpha-fetoprotein level should be assessed in all patients with chronic hepatitis delta and advanced liver fibrosis to enable early detection of HCC. Next, please. So, as I told, additional tests for the evaluation patient with the HBV infection with delta agent, it's alpha-fetoprotein is considered an additional marker for screening hepatocellular carcinoma and is most commonly used alongside ultrasound to improve detection rates. Alpha-fetoprotein is advised for patients with HBV and the delta agent who have advanced liver fibrosis, fibrosis 3 or 4, to enable early detection of HCC. High level of alpha-fetoprotein in the blood are associated with an increasing risk for HCC, especially in individuals with liver cirrhosis. Studies have shown a direct link between the degree of liver fibrosis and alpha-fetoprotein. When non-invasive tests provide conflicting results, a particular percutaneous liver biopsy may be necessary to determine the appropriate treatment strategy, particularly for patients with cirrhosis. Next slide, please. So, and international experience show us that Japan is head of the world and it's achieved a very favorable result in the treatment of hepatocellular carcinoma. Why? Because they started to do these tests. Several factors have one such factor in the establishment of a nationwide liver cancer screening program, which was developed in 1980s and involved institutions throughout Japan. Japan was the first country in the world to develop the implemented diagnostic ultrasound system for liver cancer screening. In addition to the already established cancer marker alpha-fetoprotein and other markers such PIK2 and alpha-fetoprotein L3, which were done in Japan. And these two tumor markers were included in screening tests covered by health insurance in 1989 and 1992, or 1994, I'm sorry, respectively. Japan is the only country in the world in which these three tumors markers are included in routine severity. And next slide. And if you can see, if we compare the detection of HCC in two countries over 5 years, the detection in Uzbekistan remains low, but this does not mean that there is no HCC. It means that there is poor screening. It makes us, and which one is make us think. Next slide, please. So this, those, as I said earlier, the HCC can be treated very well if we detected them early enough with sonography. However, this requires not only modern equipment, but also qualified staff. And there is a clause in the decree according to which in 2023, we can change the serve and funding figures. We plan to increase screening to 2 million people from 2025 and treatment of patients with hepatitis C to 30,000 per year. Only in these cases, we will be able to achieve the WHO by 2030. Pay attention to the fourth point. according to which we plan to start early screening for liver cancer in our country. Next slide, please. And how it is a diagnosis in Uzbekistan, it's a HCC. It is to make a diagnostic, we need ultrasound and tumor markers. It's the alpha-fetoprotein and PIVKA2, CT, MRI, and then it is a histology first. Next slide, please. And we already started to do this program. And as you can see, we did the total number of people examined for alpha-fetoprotein. It is 3,742. And a lot of patient was the alpha-fetoprotein patient with the alpha-fetoprotein is higher, is 138 person, and result of ultrasound we did together with that we did the ultrasound of and contrast MSCT examination among the patient diagnosed with the viral hepatitis B, C, and Delta. And alpha-fetoprotein, which one done more than 100. Next slide, please. It was done over the last year. And here is the result, the data that we were able to find. It is 16 from this among the patients. It is not so much, but when we did the CT screening with the contrast enhanced type of viral hepatitis among the patients with an increasing alpha-fetoprotein blood level, it's a lot of patients was in HDV virus, and 62.5 of them, it was this HCC was put together. We told that they have the HCC after the CT screening. Also HCV, a lot of a number of the HCV, HBV less, and HBV plus D plus C, it's also done. And it is not so much patients with this virus, but a lot of patients who is having the HCC, it's a patient with the B plus Delta. Next, please, slide. In terms of diagnostic, I have already mentioned quite a bit. I would like to just provide a small algorithm that we are currently using in Uzbekistan. It's a total HDV testing, then anti-HDV positive or negative, PCR testing for the HDV RNA who has a positive, we told them positive or negative. And if it's positive, we are telling them that it's an active HDV infection. If it's negative, no evidence of action, HDV, yes, they dead, but no evidence of infection. Next slide, please. What about the treatment? All patients with established diagnosis of agent Delta HBV are recommended to undergo etiologic drug treatment. So evidence graph scale. All patients with agent Delta HBV are compensative liver disease, regardless of whether they have cirrhosis or not, should be considered for the treatments for the pegylated interferon. The preferred regimen should be pegylated interferon for 48 weeks. The duration of treatment can be individual and adjusted based on HDV RNA and H-base antigen level, as well as tolerable of treatment. In addition, it is necessary to conduct non-drug treatment in indication of etiologic treatment, and as I told that pegylated interferon is mostly useful in Uzbekistan. but also Bulevirtide, which one is a block the attachment of asbestos antigen to NTCP, which prevents the virus from entering cell. But it is not in our country. I hope it will come, but no, it is very hard to find the Bulevirtide in our country. Next slide. So about the treatment, this is a table prepared by me. It is a treatment has been, so it is a regulated interferon. Again, it's a patient with HBV, the delta antigen and compensative liver disease. Treatment for 48-week, individual correction for HDV, RNA, HBs, and treatment tolerance. This treatment has been proven to be beneficial and based on high-quality RCT or meta-analysis data. Bulevirtide, it's a patient with HBV with a delta antigen. Long-term treatment of 2 milligrams once daily is recommended, can be used in combination with the pegylated interferon. But this treatment is recommended, but the evidence is based on expert option or limited data. Combination pegylated interferon and bulevirtide is a patient without intolerance or contraindications to pegylated interferon. Consider combination treatment, but it's a no grade or scale evidence. Nucleoside reverse transcriptirase inhibitor, tenofovir, alafenamide, and this NAs, it is if less than 2000 HBV DNA, I'm sorry, more than 2000 HBV DNA cirrhosis, HBV reactivation on withdrawal of antiviral treatment for HBV with delta antigen agent. They are used only if there is indication for this treatment of HCV. And this also treatment is recommended, but the evidence is based on expert option or limited data. With the compensation liver cirrhosis, it's also regardless of the presence of the detectable HBV DNA and nucleoside reverse transcriptase is a compensative liver cirrhosis detectable for HBV DNA purpose of just to do the lower of the HBV virus. Next, please. So, and our next steps, it's our national program. It's achieve a 65% reduction in population death due to viral liver disease by 2030. Coverage of all newly diagnosed HBs antigen positive patients with anti-HDV reflex testing. And we would like to do that for 2025. It's approximately 60,000 persons, and for the next years, it's increasing. In accordance with the fact that the screening indicators of HBV are sufficient due to the percentage of the prevalence of the virus among the population, at the moment work is underway to introduce a reflex testing for viral hepatitis delta among positive for HS antigen people. Next slide, please. And thank you for your attention.
Thank you so much, Dr. Khodjaeva. This was a really great presentation, and we really appreciate all of your insights and your great work and tremendous research into this area.
Thank you.
Yeah. So I'm just going to see in the chat really quick if we have yeah, there's some thoughts about screening and surveillance in the chat and the order in which to conduct them. We also have a question from Andre, who says, in terms of the results by demography, do you have any idea why especially the young people ages 5 to 17 have such a high viral load?
Yes, because it is, not all regions are having the good, connection with the GPs. They not all all parents doing the vaccination for the HPV. That is why it is this prevalence for the children under 17 years old. We will write about this everything in our publication, and I will share with audience also more deeply.
Thank you so much. Yeah, you had
Yeah.
a lot of really interesting results overall. Um, were there any differences? It seemed that the epidemiology of the virus was different regionally in Uzbekistan. Do you have any thoughts on why certain areas have a higher burden?
Excuse me, it was not clear to understand your question.
Oh, I'm
Could you
sorry.
repeat, please? Yes, yes.
Sure. It seems that different regions in Uzbekistan have higher levels of hepatitis delta. Do you know why certain areas might be more affected or have higher burden?
It is about the we are we are doing research more deeply, but it is about our borders with Afghanistan connection.
Mm.
Also, it is also about the level of education, level of the leave conduction, yes, of the lower than in the cities, and also the chance to have the vaccination, it's lower than in other countries, but mostly it's because the connection with Afghanistan.
Okay. Yeah, that makes sense. I know that there are immigration patterns,
Yes, it's
but
about the migration partners. It is. It's just my idea, one of our ideas, but we are doing the screening more deeply, and now we are trying to implementing more deeply for the national program for the screening for the Delta virus, and I hope it will be more better information about this.
yeah, absolutely. Um, Great. And then I see there is a question in the chat about being able to afford drugs, and I know that this is a big problem globally. So I think regular surveillance is very important, but also I will put and I will share my email after this webinar, but I'll put it in the question box now. So if this is an issue that you're facing, please feel free to reach out and we can try to work with you on this. Let's see. So yes, a recording of the webinar will also be sent out after the webinar concludes. And then so it seems, I noticed from one of your graphs that the rate of HDV-related hepatocellular carcinoma is increasing every year, or seems to. Is that just because of the severity of the disease, or do you have any insights into why it continues to go up on a yearly basis?
It is your question is why it's increasing HCV every year?
Yeah.
Because it's a no treatment, full treatment between the, it's because for the HCV we finally has this treatment for the HCV virus, and we are doing that, and we are doing the screening for the HBV, for the HCV, and we are giving inside the national program, we are giving the treatment free, partly free for HCV virus. And because of that, it is the liver cirrhosis of the HCV is started to be lower or on the same level, but about the HCV, we don't have a treatment. That is why we are liver cirrhosis is increasing. It's just one treatment. Which one we can do? It's a pegylated interferon. Not all patients wanted to do that, and because it is very hard to use this drug. Who is doing this, they know about that. So it is very hard, yes, and early detection of HDV can bring more effectively. And as it's shown in the graphs, also it's increasing, liver cirrhosis is increasing very, very fast between the HBV, HBV and HCV. That is why it's early detection of the HDV, and also it should be inside the screening and of the populational screening. All HBV detected patients should be screened for the HDV. And after that, they should to be, if they have the positive for the HDV, they should to start their treatment recently. That is why it will be more better, and it wouldn't be a liver cirrhosis. But we should to implement this program.
Yeah, absolutely. And it's so encouraging to see how your work and research has influenced policy and the national plan to work toward elimination. So that's very encouraging for sure. I just have one more kind of question. So are most people who are living with Delta hepatitis in regular surveillance for hepatocellular carcinoma and are being monitored regularly?
Yes, in Uzbekistan, they are monitored regularly. They are coming to the hepatological center. They having the yearly part of them. It's not yearly. It's twice a year. They're coming to the clinic of the Institute of Virology. We have the big clinic. And they are coming with the chronic hepatitis and also with the cirrhosis, and they have a treatment with which one we're doing, implementing in our institute.
That's great. I'm glad to hear because that's such an important step, and a lot of people can sometimes fall off for sure. There are two more questions that came in. One is just saying that we no longer use LFTs. We use liver enzymes and AST and ALT. And these are not functional tests. So the liver function is albumin, bilirubin. So I think just bringing that to light. And then one person mentioned if you have any thoughts on Republic of
Karakopakistan.
Yes.
Yes.
Do you have any comments on that at all? I think maybe the epidemiology there.
Yes, I showed in my presentation. Yes, it's in the table also done about the Republic of Kazakhstan. We did there. It is also not low. It is about the HBs antigen. It is 4.39% HBs antigen positives, and the Republic of Kazakhstan, it's a no data. It shows that it's a no all HBs antigen positives. There are no HDV positive. It shows like that, but I hope when we will implement it, the national screening for all patients, we will have the more deeply information about that. But it is not so high level of the HDV inside the Republic of Kazakhstan. It's also our region, and for now, it's not so big. But it's coming to also to Institute of Virology. Patients come to Republic of Kazakhstan and from another country also. Now we are also did the database together with Hanover Medical Institute, which one will be presented, I hope will be presented in EASL.
Okay, perfect. All right. Well, thank you so much for this presentation. Thank you to everyone for your questions and for attending today. We really appreciate it. I think we've come to the top of the hour. So I just wanted to close us out. So we really hope that that you found this webinar informative and valuable to your life or work and can apply some of the information moving forward. And thank you so much again, Dr. Khodjaeva, for really this very comprehensive dive into all of the great work that you're doing. For all audience members, we encourage you to complete the evaluation form when the webinar concludes. Again, a recording of the webinar and slide presentation will be emailed out to all attendees. And we also encourage you to sign up for our Hepatitis Delta newsletters for both providers and those living with hepatitis Delta in order to be added to our mailing list and receive regular updates about hepatitis Delta drug development, clinical trials, research, news, and events like this one. So you can find the links to the forums in the chat for the newsletters, and these will also be mailed out after the webinar concludes as well. So please do feel free to reach out and get in touch with us using the contact information on the slide and visit our website for more information. And we thank you so much to everyone again for joining today. We have one more question if you have time for one more. Do you have a minute or do you have to jump off?
What is the challenge of implementation effective hepatitis Delta screening and treatment program in Uzbekistan? It's our early detection of hepatitis. It's exactly for the patient who has a B virus or HBs antigen positive. We are planning to implementing all their family members for doing the vaccination for the B. And also has a Delta virus. Their patients, families should be done vaccinated by the for the B virus, and after that it is will be it's Delta virus. It's not will be the lower, yes, the risk factor. If you and everybody knows, if you don't have a B virus, it wouldn't be Delta virus. So, and early detection and the screening, doing the screening for the Delta virus, it will be early detection will be helpful because if earlier we will start our treatment, as more chance to be without the liver cirrhosis and the hepatocellular carcinoma. And exactly.
Absolutely. Yes, early detection, vaccination, prevention are key and are so important. Absolutely. Great. Well, thank you so much again. We really appreciate you joining and sharing. And thank you so much to everyone for joining. And I hope you have a great evening or day, rest of the day.
Me too. I hope my presentation was helpful for everybody. Bye.
Absolutely. Bye. Take care.